Hello, everybody. Thank you for the nice introduction. Thank you for having me here in Porto. I had the luck to be it's the second time in Portugal in the last 2 weeks, so it's really nice to see that in the whole country it's moving a little bit, especially regarding the legal situation, which is now offering a little bit more possibilities here. There's some work to do. There's a lot of, we need training, we need products, I know, but at least the legal stuff is done. So nice to see so many people here attending today. Good. I would like to start. You can see I'm going to talk a little bit about pain, cannabis in pain treatment. We have heard from Daddy before already a little introduction. I'm going to have a brief introduction talking about generally chronic pain and then getting a little bit more specific in the possibilities of treatment with cannabinoids. So about me, we pretty much said everything. So I'm going to skip to the next one. Here we can see the discovery of the endocannabinoid system. This we have heard today already several times, but it's interesting because in 1964, Raphael Mechoulam in Israel wanted to find out what is the psychoactive component of cannabis. Why, if we take it or if we inhale it, why do we have this psychoactive effect, this psychotropic effect? And he found out that THC is the responsible substance. A couple of years later, you can see, of course, we want to find out why or where does this substance get attached to create this effect. That's where, let me see where the pointer is here. That's how in 1990, or in between 1988 and 1990, the CB1 was discovered. So we understand, okay, THC from the plant plus CB1 in our brain is the psychotropic effect. Then we find out, okay, if we have these receptors in our head, why we have them if our body doesn't produce substances where it gets attached. So there comes anandamide in 92, the first endocannabinoid our own body produces. Of cloning of the CB1, we discover CB2, and then we discover, okay, there are more receptors related to the cannabinoid system. We have cannabinoid receptors, and we have cannabinoid system-related receptors, which would be, for example, TRPV channels, GPR55, and several others. So how does all that work? So we have endocannabinoids our body produces. We have phytocannabinoids, the ones we take out of the plant, and synthetic cannabinoids, which are created in the laboratory. So all those three components act through the endocannabinoid system we have in our body. So we try to modulate. It's a little bit like playing marionette over our own system in the body with external substances, and that's how we can modulate those functions for medical benefits, like you can see through CB1, CB2, and the other receptors. So these are the main functions, let's say, of the endocannabinoid system. This I didn't invent by myself. This is from Vincenzo Di Marzo, and he describes the main functions of the endocannabinoid system with eat, sleep, relax, protect, and forget. So if we look at this in our body, we are fully competent of, we eat well, we sleep well, we can relax, we have neuroprotection, and we are able to forget traumatic experiences. We live kind of good. Yeah, we're feeling good is a very important basic functions of our body. If they're all accomplished, we are in a good state, so we can see, okay, this is a pretty big and important task the endocannabinoid system has in our body. Here, this is just repetition. We have heard that several times today. This is a lot of different functions we can see the endocannabinoid system has. It goes from hormones, over appetite, over sleep, over pain, digestion, cell division, etc., etc. You can see there are a lot of different functions in our body, and several of them, or a lot of them, very, very important for our functioning and for the well-being as a human. So, getting a little bit more in detail about cannabinoids and pain, the subject of the speech today. So first of all, epidemiology of chronic pain. So what do we know about chronic pain? Chronic pain is increasing in prevalence. Yeah, doctors are doing our work, researchers are doing their work, we all live longer, and we are able to treat conditions which a couple of years ago were not treatable. So frequently, the negative side of all that we live longer, we treat more, etc., is that we have some side conditions, which is frequently chronic pain. Yeah, we have, for an example, we have a motorcycle injury 20 years ago with the surgical possibilities. A patient, maybe he would have died. Now we can help him. We can help him and fix the broken bones, etc. But as a side effect, we have the pain. So this is for a very easy example to see, okay, why we have this increasing amount of pain. Prevalence in Europe, 19%. You can see it's not just affecting one or two, it's affecting a lot of people. Actually, so many that over 50% of the medical visits are at least related to chronic pain. So this is a major problem, which is of course mainly for the patient who has to live with it, but it's overpassing this as well. It's not just for the patient, it's the healthcare system, and it's also the doctors, etc. All this system is like overwhelmed from the condition and from the incomplete treatment of chronic pain. So we can say, right now, treatment is not especially satisfactory. I mean, in some cases, yes, of course. I'm not saying that we're doing a bad job, but there are just a lot of people with chronic pain where the treatment or the current available treatment is not helping enough or not helping satisfactorily. And it's unsatisfactory in terms of efficacy, toxicity, and adverse events. We have a lot of people taking more and more and more and more and more pills because of the pain. We start with the pain treatment, then we start to treat the side effects of the pain treatment, then we start to treat the side effects of the pain treatment, etc. We know that the easiest way to say it is the ibuprofen. We start to take it 3 times per day, then we get like stomach problems, then we start to take the omeprazole, etc. And if we have nausea, we take ondansetron. If we have this, we take the other one. So we all know from relatives, family, etc., a lot of people after a certain condition and with a certain amount of age, we are taking more and more and more drugs. So this is important, especially as well, to the pain treatment, because if we get to the point where we use opioids, we have severe problems in terms of toxicity and adverse effects. We have the opioid overuse. This is frequently seen as a problem, especially that's in the US or in Canada, and it's not affecting so much Europe. I think we have to keep that in mind as well here. This is substances which are very, very, very important. I don't want to misunderstandings that I'm against opioid use. No, I'm against the use of the correct medical drug for the correct patient. That's it. We have patients where we need it, and we have others where we don't need it. Just the overuse to say, okay, this is working, this is good, and this is bad. It's not working because I think we have to see the patient more individually. And you can see this is, especially in the USA, becoming a serious problem. Yeah? And it's a major issue in public health, especially as well related to the high amount of medical visits and to the unsatisfactory in terms of efficacy. So, a little bit, what is the situation? What do we know? What do we don't know about the treatment with cannabinoids in pain? So from preclinical studies, we have heard it several times today, preclinical before humans, so human cells in laboratory, animals. What we have seen there is that we have multiple receptors related to the endocannabinoid system which are involved in the modulation of pain. So this is not just CB1 or CB2. We have several of them which are related, modulating the perception of pain in our body. The CB1 in the central nervous system is related to the reduction of the central stress response. This is an interesting thing because our body is under permanent stress if we are under chronic pain. So we are not feeling very well if we have all the time our brain is telling us pain, 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 pain. So this creates stress, which you can see, of course, it's an important fact, especially to psychosocial properties as well, anxiety, depression, etc. And in terms, CB1 is related to an anti-hyperalgesic effect. This is the hypersensitivity to stimulus which normally would not create pain, but in this case they do. It's quite frequent in fibromyalgia, for example. So CB2, we have seen that CB2 receptor increases when we have a tissue lesion or inflammation. So our body creates more CB2 receptors where it's needed. So it's a pretty interesting thing, like an auto-defense of our body. And CB2 is related to turning a pro-inflammatory environment to an anti-inflammatory environment. So this is for inflammation purposes, it's also an interesting point. What else? TRP1, CB1, CB2 are co-localized and especially in parts of the brain pathways which are related to the modulation of pain. the nuclei of the posterior horn, periaxial gray matter. These are all substances which are highly important for the transmission of information of pain to thalamus, to the regions of our brain where we perceive it. So it's interesting that especially there we have those receptors pretty close to each other. Another interesting point. And we have interactions between cannabinoid and opioid receptors. So we still don't understand completely how all that works, but if you look at it, we see, okay, there's at least something which is interesting. We should find out more about this because there's a lot of interactions which can be pretty helpful in the treatment of chronic pain. So let's get a little bit in the clinical studies. First of all, in acute pain, until now we haven't seen such big effects. Yeah? There's no convincing evidence until now that cannabinoids are helping in states of acute pain, but in chronic pain, yes. I've selected two examples here because there are several studies. These are the ones used, nabiximols spray. This is the Sativex spray, which you can see. In the study, plus in the meta-analysis, we have an effective reduction in chronic pain. And in another one, we saw a significant reduction of pain and significant reduction in spasticity associated with the disease. Again, this is two examples. These are more. This is from the YAMA study 2015, which is the one which was based for the regulatory law in Germany 2017. So just to see, there are several of them, and the list goes on. This is just an extra that you can see, okay, in chronic pain, we have more studies which can help us. So let's get to a point where we have all the studies, and what we doctors like a lot are guidelines. Guidelines are the new thing, 2019. In the last years, for me as a young doctor, I grew up with guidelines. Everybody talks about guidelines in studies in the university, especially when you finish university. There are cardiologic guidelines, dermatologic guidelines, pulmonary guidelines for everything. And it looks almost like we don't need the patient anymore, we just need guidelines. And that's a little critic, I think, especially, I'm a GP, I'm a general practitioner. I like to talk to my patients, I like to have them around to understand a little bit the context of that. And then to combine guidelines with patients, I think it's a good thing. We should not just watch at them. But they're important for the use today, so let's have a look what the guidelines say. So, guideline of the European Pain Federation says that we should use cannabinoids as adjunctive medication if their first and second line didn't work. Okay, let's say another one. Here we can use it, okay, as a second or third line treatment in central pain, just in multiple sclerosis. Okay, as a third line option. And we should not use it. So, these guidelines, pretty complicated to say what should we do. So they are not very conclusive, those guidelines. It's a little bit like this. Should we do it? Should we not do it? Maybe later. Maybe let's have a look first. Nobody understands very well. We don't get a lot of information out of this. So why? Why we have those problems in those guidelines and those problems with the different outcomes in the studies? If we watch, especially in chronic pain, it's a problem because we go back and it's one of the oldest indications of medical use. It's one of the first ones which were studied. And there are several problems with the ways how those studies were done. But the thing is what we do today, I'm going to get into more specifically what problems are there later. But the thing is what we have heard today already in different speeches. There are not so many new studies about chronic pain nowadays. What we did in the last years was increased in a crazy amount. It's the meta-analysis of the studies from before. So meta-analysis means we look a lot of clinical studies together and try to draw a line with the results of all of them. The problem is if the basic studies didn't change, the meta-analysis is difficultly going to change as well. So what's the problem generally? If we look at all those studies, we see there's no differentiation, like they said before, about the products used. So they're comparing cannabis for pain. Two generic things, okay. All kinds of cannabis in all kinds of pain. No, important, we're talking about what kind of cannabis? THC predominant, CBD predominant, which terpenes, which other cannabinoids? Inhaled Suppository, oral, what do we say? What are we talking about? And the same as what kind of pain? Neuropathic pain, inflammatory pain, acute pain, chronic pain. We have a lot of different types of pain. We need to do it more specifically. And not just about the products used, about the administration routes. It's going to be very different if we smoke, inhale, vaporize, sublingual. The effect is going to be different. The side effects can be different. And the parameters evaluated as well. This was it's a nice pass from Daddy from before. He was explaining it. It's just frequently we watch just intensity of pain. That's what we search in those studies. We want to see if a pain with an intensity of 8 went to a intensity of 6. That's an important part, of course, but it's not the only one. Yeah? Are people able to dress themselves, to eat, to live their lives? Do they go out? How do they feel generally? Do they want to see their nephews, or they're just at home sitting on the sofa, don't move in, and don't want to see anybody? Important difference, which we have to look as well at when we talk about chronic pain. The dose sounds quite stupid, but frequently in a couple of the studies was not even the dose said, or not the proportion of the concentration of THC. For example, if you say, okay, we're talking about 1 gram of cannabis, what kind of cannabis? Again, you understand, it goes a little bit in the same direction. And another thing is the blinding, which is it's a little funny point, but of course, everybody knows either they have tried cannabis before, or they at least know that there's some mystical part with it. If we now do clinical studies, and people expect a certain effect if we treat with THC, and they don't have it, they're going to know that they're getting placebo or not. Before, now we have the extracts, we can do it better. Before, it was even the problem with the smell and the taste. I mean, how do you give to somebody cannabis inhaled or vaporized and to other not, and how do you do it with effect? This nowadays we can do. But it's a problem, of course, to know it's easier with the pill than with an extract of cannabis, for example. So we have to check. That's why a little bit the problem is why we have so many different outcomes from those studies, and that's what makes it also confusing. And we have to ask ourselves a little bit the following questions. Are we using the correct preparations for the different pathologies? Not everything is the same. We expect from cannabis to be like the super weapon for every kind of diseases, from epilepsy to Parkinson to sleeping problems to autism. This has nothing medically to do one with the other. Maybe in the future we find out that through the endocannabinoid system, yes. But right now we expect it to help anywhere, and we don't talk about, we don't specifically say what we are getting. Yeah? So this is like from a car which we expect to run with oil, gas, petrol, olive oil, or whatever. Not working. We need to do it more specifically. Yeah? The second point, are we using the right parameters? Of course, this is a little bit going direction what I've said before. And then here is this the right way to evaluate it. Of course, all that what I was telling before, and I'm going to talk a little bit more later about it, where cannabis is helping besides the intensity of pain. This is very difficult, like life quality, ability of going out of the house, enjoying, wanting to see the nephew, the kid, or whatever, and not sitting grumpy at the sofa. How you evaluate that in a statistic way and you get a number out of it. I mean, there are questionnaires and there's a lot of stuff to do, but it's quite difficult. You can easily say, okay, from a scale from 1 to 10, how intense is your pain? 7. It's a little bit easier than how would you evaluate your life quality in the last 2 weeks? You need to write an essay. So this is a little bit a complicated point up to here. So let's see which parts does cannabis touch, which can help us in states of chronic pain besides the pure reduction of the intensity of pain. So there we have found out, for example, this. Cannabis reduces the central stress response. We were talking about it before. And we can see that chronic pain can affect us so much that this system of control collapses. We have predominant sympathetic, we have the cortisol going up, our body is under a feeling of permanent stress. So helping us to reduce this central stress response can be a pretty important point when we talk about the treatment of chronic pain states. Cannabinoids participate in the elimination of content from the memory. It's affecting our short-term memory. This is frequently seen like a negative thing. We have seen before that forget part was of the main functions of the endocannabinoid system. That's, for example, why in post-traumatic disorders it's used, because sometimes to forget, it's a good thing. And if we decide that, so this is very important, especially because what we are seeing here, around 70% of the patients in chronic pain, they fulfill criteria of trauma. So they have a severe problem with that pain memory. We have a pain memory, we have a sensibilization process if we talk about chronic pain. So this is not just a punctual state, this is a main process behind it. We have, of course, an affection of psychosocial behaviors or symptoms like anxiety and depression. So all of people, everybody who has can believe, like a lot of people know people with chronic pain from their families or friends. So this is, of course, affecting mood and situation. They don't sleep good, they don't want to go out, they don't want to do anything, they don't want to eat, they don't want to sleep, but they cannot sleep, so it's getting like in this negative circle. So if we can reduce anxiety and depression and we can just lift up that a little bit so people say, well, I'm not feeling so good today, but well, let's go around. And then you're outside, you have a little sun in your face, you maybe meet the neighbor and you talk a little bit, and life is a little bit better, but it helps you just not talking about intensity of pain, but it helps you a little bit to change that negative circle into a little bit more positive circle. And that's what in these cases can be very, very helpful. And it's not even, it's just related to this little changes in your life. Of course, we have the relation to the opioid system. We have seen that using both together, we can reduce the opioids. Yeah? Up to what point needs to be defined. But reducing the opioids, we have less side effects, we have less affection of, we have less side effect, which gives us back life quality again. And we have improvement of symptoms frequently associated, which would be, like I said before, sleep, appetite, etc. So we can see, besides the intensity of pain, there are a lot of points which seem to be at least remarkable in this point, at least interesting to look at them before we say, okay, this is helping and reducing moderately pain. Point. No, there's more to talk about. And that's what I want you to show here. And there's this. It is suspected that the endocannabinoid system affects more the limbic system than the sensory system, and that's not just affecting, or a little bit affecting the intensity of pain, but that it's affecting more the perception of pain. So maybe we have the same pain of 7, but it's not the pain that we want to jump out of the window. It's a pain we say, well, what I'm going to do? Let's be more motivated and let's do something with it. So this is an important point, which is, again, quite difficult to calculate in numbers. So besides that, a little bit going to the actual political situation a little bit here. I come from Germany. There we have now for 2 years medical cannabis. It's not perfect. It's not everything shiny and funny. But what can we do to integrate cannabinoids into an ongoing health system? Yeah, this is an important point of where should we start and where not. So first of all, cannabis or cannabinoids are neither magic or myth. Yeah, we have a big problem. Everybody who working with cannabinoids or wanting to learn about cannabinoids, we are confronted permanently with those two extreme kind of stories. Half of people say, well, you're giving drugs to people. And the others say, well, this is magic and helping me. My hair was falling out and now it's growing again. Whoa. We have here indications, we have contraindications, we have effects, we have side effects. It's like a lot of different other medical substances as well. So this is not the magical thing which can be frequently seen in the internet, somebody with the super severe Parkinson and then taking one inhalation of cannabis and everything is perfect. I work for 4 years now with this and I haven't seen that. It helps, of course. That's why I'm here and we're working with that. But if it would be that magical, I would be really proud about what you're doing. So it's important to say, okay, neither one extreme nor the other extreme. We have to treat it like a medical substance like we're doing, and we have to research more about it, but not this mystical stories, not at the negative and not at the positive side. To end the stigmatization and the fear. This is one of the main problems. How we do that? Education. The only thing to end with this is education. We have all, and this is not a Portuguese problem, this is a worldwide problem. We have a problem with education and knowledge about cannabis because we are used to see cannabis like it was seen in the last 100 years. Yeah, in the last 100 years, cannabis was seen as those weird substance. You go in a dark corner of a park, you buy something green, you roll it in some paper, you smoke and you get high. That's the perception of cannabis. That's the perception of cannabis. That's illegal and driving is all crazy. Well, this is the last 100 years. If you look further, cannabis is used since 2,000 years before Christ, Chinese medicine, Ayurvedic medicine, Egyptian medicine, in Europe since the 18th century, etc., etc. So you can see we have a long history of using it. Just because some substance can be used as a recreational substance doesn't mean that it's necessarily bad. And that's why we need education about this and to lose the fear, because there's this big stigma of drug, and this is not just affecting or being dangerous for the patient, because of course the patient has fear. Wow, they said me it's a drug, now I'm getting this for my treatment, this is a problem. This is a problem for the doctor as well. We have seen that in a lot of different countries. Doctors starting to work with cannabis, they were the weed doctors. A little bit laughing about them, you're directly the weed doctor. This is a lot of people in, let's say, a little bit more conservative medical circles, which there frequently are in a lot of countries. This is not nice to see, and I say, look, a little bit laughing at the weed doctor. But now this is changing. With education is changing, because that's why congresses like here are so important. Yeah? Important thing as well, the complete information about positive and negative things. We tend to be too positive or too negative. We have to see that rationally. People in favor of medical cannabis, they talk about the fantastic effects, and people against it, they just talk about all the side effects. We have to be rational. There are studies. We just have to look at the studies and to read the studies and to see what is there. Then it's important to represent neither the super positive than the super negative one, like the one like it's shown in the studies like we know. And this little German part, das Rad nicht neu erfinden. And the question, what does he want to say with that? Well, this means we don't have to reinvent the wheel. Yeah? And why not? Because cannabis is not so different. I mean, it's not so different than other substances we are using as a doctor. We have substances with effects and with side effects. We have substances which can be psychoactive. We have substances which can be addictive. We have substances which can create problems in elderly so they can fall down. So this is all nothing new. We have them in the pharmacy and we prescribe them day by day. So we don't need to be neither more than less worried about using cannabinoids. We just have to learn to use them in the right way. That's it. That's nothing new about this substance. Of course, then we need to find out a little bit more and to research more to see in how many different parts we can use them. But we can use them right now in a perfect base, and it's nothing more, there's no more tricks around it like there are in different other medical drugs we're prescribing on a daily basis. Yeah? Well, to show that, there was one part missing from the NHS is exactly what I was saying. So we can see that the effects, the risks and the effects normally are within the range of effects tolerated for other medications. So it's exactly the same. Of course, there are risks of using cannabis, and there are benefits of using cannabis, but which medical drug doesn't have risks and benefits? Everything. So this is nothing more and nothing less, and we always try to push cannabis in this kind of parallel medical world. I think it should not be there. There's no different values for this one. We should integrate it in our daily practice, doing it with the knowledge we have. That's another substance which can be used in the medical practice on a daily basis. Key aspects to resume a little bit. Cannabis are effective in reducing chronic pain, helps better to tolerate this pain. This is a very important point if we are talking about the patients. This is maybe one of the most important points, because we doctors look at the intensity. The patients frequently doesn't look at the intensity. They don't care if it's 6 or 8. They want to see how is my life with this 6 or with that 8 of punctuation of pain. We have a reduction of stress, fear, etc. symptoms associated. More symptoms associated. We have the synergistic effect with opioids. and they seem to not be effective in acute pain. So, and, very important, generally very well tolerated, poorly toxic, and safe. So if we know how to work with them, this is no more danger than in other drugs as well. So to get to an end, I want to leave there a statement which is from Ethan Russo. It's one of the most known researchers regarding the endocannabinoid system. He was last year in Portugal. This year he's not here. But it's a very important statement, especially for the doctors today, which are here, because there's a part in the Hippocratic Oath where we, as a doctor, we have to swear, everybody of us swore it, that we swear that we do the best for our patient in the most educated way. Yeah, so we need to be updated. Our knowledge doesn't stop here. And not knowing does not protect us from not using something. So if there is the possibility of using the endocannabinoid system with all the studies there are, just because we say, but I don't know, doesn't protect us for not giving the patient this possibility. Yeah? So I want everybody to be clear that we need to be updated for getting in front of that big problem with chronic pain. So I want you to be there, educate yourself, go to those events, look for those events, and educate yourself for the patient, because that's a severe problem we have right now with chronic pain. We can help the patient, and they have now here in Portugal the legal possibilities, and there's two problems: that we have no doctors knowing how to work with this, and we have no products. And it's not possible that you have the legal frame without the rest. We need to push that forward so to the patient actually gets the product they deserve, because there's a lot of countries and a lot of places where we're already using it. So look forward. We're the European Union. We can learn from each other. We should exchange that openly, and we don't need to discuss from the beginning again, does it help, does it not help? No, half of the world is already seeing that it helps. So we don't need to discuss against the evidence, the medical evidence. It's not different in France than in Italy, than in Germany, than in Israel, than whatever. There's one evidence. And if we have seen it, that it works, why not using it just because of fear? No, we can overpass the fear of education. With that, I will end. Thank you a lot.
Yeah, we go there. So far, I guess we have two questions in the app. Whatever you want. Yes. Specific questions about patients and revealing the patient's life won't be treated here. They should come to the open consultation tomorrow. There's one question that way. And before starting the questions, a quick announcement. The first speaker after the coffee break will do his presentation in Portuguese. So for those of you using the devices, the channel 1 will be Portuguese anyway, but you won't need it. For those of you who will need translation for English, please request your device in the coffee break before coming in, and the channel will be number 2 for English. So it's Dr. Paulo Freitas Tavares after coffee break. He will do his presentation in Portuguese. And now, questions?
Sure. This is from Leonardo Suiza. There you are in the back. This is a big philosophical question for you.
All right.
Okay. Do you think the prohibition of cannabis is linked to the growth of neurodegenerative diseases in the past decade? Humans had phytocannabinoids in the food chain for centuries. Maybe we're facing a deficiency of cannabinoids in our endocannabinoid system. What are your thoughts?
Wow, read it again.
Yeah, I told you.
Pretty epic, important question. All right.
You want to read it?
Can I have,
let
me have a look at it. Let's go for parts.
Is it related to diet and not having
To answer the
sufficient...
first question, do you think that the prohibition of cannabis is linked to the growth of neurodegenerative diseases in the past decades? No, I don't think so. This is a super important question, but there's not going to be an answer to that, which is at least I don't believe that it's so simple to say, okay, we didn't use it, and then it just appears. We have used, the use of cannabis is highly dependent on the region, on the world where we are. There's different traditions, so this is not just a worldwide thing. We can see now that it's related to the industrialized world, if we want to say it like this. We have different parts of the world where we used a lot of cannabis in the past, or where we didn't use it, and we don't see proportionally that in those regions there's a more higher or lower amount of neurodegenerative diseases. Humans had
the deficiencies in our diet. Could that have any relationship?
I mean, it's the diet regarding the endocannabinoid system. It's very important. Yeah, we can see that certain omega fatties are important for the building of the endocannabinoids. Of course, we can enhance. There, the first studies shown that we can enhance our endocannabinoid system with the diet. Now, this is a pretty new era. Yeah, so we are at the very beginning of understand this, and I'm pretty sure that it's important.
The next one.
It's pretty sure that it's an important thing in the future, like everything. I mean, we know we can influence lipids with our diet, we can influence blood sugar with our diet, we can influence a lot of different factors of our body with the diet, so this is going to be one more. Up to what point and how? There we have to wait a couple more years and we'll do a couple more studies to find out. But it's a super interesting subject, for sure.
Thank you, Carla.
Thank you. Now, the next question, it's 2 questions from Ana Rita Delgado. Yes. So, first question, what is your opinion about schizophrenia as a side effect and how to tranquilize the patients about it? First question. Second one, do you have experience in treating burning mouth syndrome?
Okay. To schizophrenia as a side effect. This is something which is highly talked about in the community. It's a very important point because it's one of the first scares we have. We say, wow, we use medical cannabis or we use cannabis and schizophrenia is like a big thing. We have to look where that information comes from. Yeah, we have those studies. That's one of the oldest studies and side effects. This is not known for a couple of years. This is coming out of I think the 80s or the 90s where those studies come from. And first of all, those events or those studies who have showed us that in recreational use and inhaled smoked cannabis. Yeah? So that's two points where we part, which is not the same like a medical cannabis use in the way we are doing it today. We don't have the peak of THC, we use fewer amounts, and it's not just recreational use, it's a controlled medical use. Yeah? That's the first point. Then, what else have we seen regarding this subject? We have seen that it's not the chronic cannabis use which provokes schizophrenia. We have seen that a high peak of THC, intoxication of cannabis, can be the trigger for a schizophrenic event if we have a genetic predisposition. So it's not affecting everybody, it's affecting people who would have a predisposition, and it can be a trigger. It's not, a trigger can be as well a car accident or a traumatic experience or a lot of different other things. So we have to be careful in which relation, where we take that information from and where we put it. Do I mean with that we should not spend attention at all to that and just like treat it? No, it's a very important point. We have to keep that in mind, of course. But again, the risk with that is this high THC peak, which we have if we use, for example, cannabis in a controlled way, and with enough amount of CBD. In my speech from tomorrow, we're going to see that the toxic psychosis, which can be caused by cannabis, is the level of THC tolerated before getting to that level is way higher if we use THC combined with CBD than just THC only. So this is another factor which is very interesting to look at here. So we have to see where does it come from. We have to see what use are we giving right now. And I think, of course, I mean, severe borderline disorder, severe psychotic disorder, bipolarity, schizophrenia, in those patients, we have to be very careful with THC. It's contraindicated some kind of way. In low amounts, we can use it. CBD can help, which is shown in other studies. We have to pay attention with that. But I don't think if we're talking about the controlled medical treatment, we don't have to be scared about these possibilities of that it can happen. We have a lot of different other drugs where I would be more scared that somebody gets a hypotension and falls down, breaks his leg, than of getting a schizophrenia because of the treatment.
Thank you. We still have another one, yes?
Okay.
Did we talk about burning mouth syndrome?
Oh, I'm sorry, you're right. You have experience in treating burning mouth syndrome.
The burning mouth syndrome, I don't have a lot of experience, I'm sincere. It's something which is not very frequent. We had 1 or 2 cases in Calapa. One worked out really good, one didn't work out at all. As I know, there are no publications about it, or almost no applications about it. It can helping with, it's some kind of neuropathic disorder, so this is normally where it can help. Through it, that you have it in the mouth, you can use it topically. You have a topical and a systemic use, which is quite helpful. So I believe that if we know more, maybe we can find out more about that, but the situation with the studies, it's very rare, and the patients I've seen, it's very rare as well, so I cannot give a lot more information about that.
Thank you. We have one more question in the app from Felipe Guimaraes Torres. Are there any guidelines in Europe that you're aware of for cannabis prescription for chronic pain?
For cannabis prescription, there was before one of the European Pain Association. There are guidelines. They're pretty conservative, and in my opinion, people are a little bit scared. Yeah, it's always like as a coadjuvant treatment in the 3rd or 4th line treatment. So if nothing more helps, you can use it because whatever. Alternatives, that's when we doctors start to use gabapentin or antidepressants just to see, let's see, it's try and error. So there's a lot of people are trying like with anti-epileptics or whatever to see if with this or with some orphan drugs to see if that works. This is, in my opinion, it's not the right way. In these cases, we can use cannabis, it's helping. In my opinion, we have a lot of cases where it should not be the 3rd or 4th line treatment when we have 5 different diseases already and 20,000 drugs already. We should use it at the very beginning to prevent. Yeah, because a lot of disorders we can prevent, for example, anxiolytic disorders, all this development of this brain pain memory, etc., in a controlled way as a coadjuvant treatment, we can prevent that, and we don't even get to that point. So I would see cannabis either in the last option, like a palliative care, or the first option to see, because me as a doctor, I would start with the drug with the fewest side effects. Simply like this, and then you can, too stronger you can always get, but you don't need to start when you have anxiety, you don't need to start with diazepam. You can start with something lower, and if with the CBD in a controlled way it doesn't work, you can get to the diazepam. You can also get to the opioids or the whatever, but we should start with the lowest one to see, is it enough? And then we go up. We shouldn't start with straight away with the top.
Thank you. We have time for one more. It's the indication we have, and it's on the back.
Good afternoon. My question is connected with concentration in your clinical experience. So we have spoke about the chemical complexity of the plants and the varieties that will impact on the prescription. And also we know that in terms of actions, the doses can act as supporting the endocannabinoid system. It can modulate a release and recapture of neurotransmitters on the synaptics, or can block totally these neurotransmissions. So I would like to know, even considering that there's other things about adipose tissue and distribution volume on a patient, how do you think when you decide which dose to use in a patient?
The first rule of all of this is start low, go slow. Yeah, that's the main thing. We as a doctors are used to guidelines and precise dosing that somebody tells, okay, in this condition, 3 times per day, 500 milligram of this. With cannabinoids, this is not working. Yeah, this is highly inter-individual differences. But as well, this is nothing new in medicine. With opioids, it's the same. There's no exact dosing. We can start it like this, but often we have to titrate up, so it depends. Now to your question, how we decide, how we start, how not, a big factor is like experience, yeah? And this is related to how you do, I mean, in my opinion, the most important thing is a well-done first consultation, first medical visit, with enough time where you can get to know the patient, you can talk through it with the patient, you can explain effects, side effects, possibilities of side effects, you can guide people through that, and you can learn about what kind of person you have in front of you. Yeah, because if there's somebody, of course, the dosing is going to be different if I have an 80-year-old woman who never tried cannabis and start with chronic pain, or I have maybe a girl with 28 which had an accident and has chronic pain because of this. It's a different situation. As well, it's important to know I frequently ask my patients, how do you normally react to alcohol, to other drugs? This is not an indication, this is not giving me a proof of anything. But if you have time to talk with the patient, you get like a notion about what kind of person is he? Does he normally react sensitive to drugs or to alcohol or other substances or not? And with all these little signs, you have an idea, or I have like an idea, okay, in this patient, I prefer to start lower and then we titrate up. In this, we can start a little bit up. Another important question is, did you have previous experience with cannabinoids? Have you smoked cannabis anytime in your life? If they say yes and it was horrible, wow, then let's start better on a lower dose and go step by step, especially if we talk about THC. If they say, no, I smoked it when I was a kid and it was fine, okay, then we can dose it a little bit up. I mean, this is all situations where we have to find and information we need to find out in the first visit. And I think as a doctor, in a lot of diseases and a lot of moments, we should take us that time and talk a little bit more to the patient, because a lot of questions we search, we have them right here, sitting in front, maybe half a meter in front of us, but we don't see it because we're looking at the computer or guidelines or whatever, and we don't ask the patient. So this is one of a good example for that.
Thank you, Janosch. Before leaving 3 points, so remember to pick up your device for translation for the next speaker if you don't understand Portuguese. It will be performed in Portuguese. Please take some time to rate the speakers on your coffee break through the app. And let us remind you that the app can be used after the Congress, and there are several surveys inside so that you can fulfill again during coffee break. And now, yes, it's time for you.
What time should we be back?
We should be back within half an hour at, you do the calculation, 10 to 5, 5:20.
5:20, everybody. Thank you.
Thank you.